Good morning, everyone. Welcome to the Denver Museum of Nature and Science at Home. I'm Kristen Uhlenbrock. I work at the Institute for Science and Policy, a project here, the Denver Museum of Nature and Science. So if you're joining us for the first time, welcome. And if you've been here for all four, welcome back. Hope you've been really enjoying the series that we've been providing. This COVID series is about bringing you scientists and experts who are working on the cutting edge research, as well as those who have the firsthand knowledge about this pandemic, including how it's impacting us here in Colorado. So whether there's something that you've been hearing about in the news or just a question that's been on your mind lately, we definitely want to know what you're interested in learning about, because this series is meant for you. I want to take a moment, of course, to recognize and extend a huge thank you to our partner in all this, the Colorado School of Public Health, and in particular, Dean Samet. Dean Samet really has been a true thought leader and partner in helping us put this series together, and most of our speakers would not be possible without his involvement. So thank you, John. If you've missed previous episodes, you can actually find all the written recaps and the recordings available if you go to institute.dmns.org. We have a nice landing page there where you can kind of look at everything that's we've gone on in the past, as well as we queue up future ones. That information will be available there as well too, so you can register. So today is going to be very special. I am really excited, honored, and privileged to have two frontline medical workers with us today. They've been working tirelessly to diagnose, treat, and improve patient outcomes in the ICU here in Colorado. So they're going to be sharing their own personal stories about what life is like in the ICU, both for patients as well as for our medical staff. So they're definitely going to be bringing the human element today. So before I get started, I do just want to provide a couple of those small housekeeping items. We encourage you to chime in with your questions. The format today is going to be very different than those in the past. It is not going to be presentation heavy. In fact, we have no presentations. This is going to be a conversation. So we really want to try to incorporate all those questions that you have. For those of you joining us here on Zoom, you can type those into the chat feature and we'll try to incorporate those throughout the morning. If you're tuning in to our Facebook Live, go ahead and drop in any questions you have into the comment feature and we'll pull those over and try to incorporate those as well. Again, apologies in advance if we don't get to all of your questions. And we do encourage you to be very polite and cordial and respectful on the chat feature so that we can kind of keep track of all the great questions coming in. Okay, without further ado, let me introduce our two speakers today. I am very excited to be joined by Dr. Marc Moss and Traci Priebe. So Traci is a charge nurse in the medical ICU at the University of Colorado Hospital, where she oversees daily functioning of the unit. She's been working in the hospital since 2013. Her work focuses on patient-centered results, as well as supervising and mentoring staff. She has her degree in nursing and is a registered critical care nurse. She also has undergraduate and graduate degrees in psychology. She also volunteers with Project Cure to help supply protective equipment to under-resourced countries actually around the world. They're excited to have Traci joining us today. Also, our other speaker is Dr. Moss. He is the Roger S. Mitchell Professor of Medicine and head of the Division of Pulmonary Sciences and Critical Care Medicine at the University of Colorado School of Medicine. Dr. Moss's research is in critical care, such as identifying new treatments for patients with the acute respiratory issues, which is very relevant, of course, to those COVID patients, in addition to studying burnout, post-traumatic stress disorder, and wellness in critical care healthcare professionals, specifically ICU nurses like those that are Traci Priebe joining us. He has had an outstanding career mentoring and serving in leadership roles, including recently as the president of the American Thoracic Society. Good morning and welcome both Traci and Marc.
Thanks for the invitation.
Great, we're excited to have you here today. So before we get started, maybe both of you could just talk a little bit about what is your role in the ICU, right? Really kind of tell our audience here, what is it that you do? And maybe we'll start with Traci and then we'll go to Marc.
Sure. Hello, thank you for the invitation here. It's very nice to speak with you all today. So as Kristen said, my name is Traci. I've worked at University of Colorado Hospital in the medical ICU for coming on 7 years now. And Since COVID has begun, I have transitioned to a newly built ICU, what we call a COVID ICU, and I have been working down there for now about 2.5 months straight. So my role is very similar in that new ICU as it was in the medical ICU I was working in prior, where I'm a charge nurse, where I oversee the unit. I supervise and mentor the bedside nurses that I work alongside with. I do a lot of collaboration and facilitate communication with interdisciplinary services. I just try to support my nurses clinically from the administrative side. I help facilitate admissions and transfers of patients in and out of the unit, in and out of the hospital through the emergency department, as well as outside hospitals. So do all of that, as well as assisting in patient care and working very closely with wonderful providers such as Marc Moss.
Thank you. Marc, can you tell us a little bit about what you do?
Sure. So I'm a pulmonary critical care physician, and as an attending in the intensive care unit, I oversee the care of the patients. The one thing I like about the intensive care unit is it's very multidisciplinary, and we work as a team. So Traci and I work together very closely caring for patients. Because the patients are so complicated with multiple medical problems, you really need a group of healthcare professionals with diverse yet complementary knowledge base. We also have trainees, so residents, medical students, fellows. So part of the job, in addition to caring for the patients, is to teach people how to become excellent healthcare professionals in the future.
That's great. Thank you. So we're going to do something different a little bit today, folks. We're going to show you a short video clip here. They say a picture is worth 1,000 words. So we have this really lovely video. It's going to be no more than 2 minutes that we're going to share with you to really give you an insider's look of what's going on inside a medical ICU unit. So let me be patient with me as I cue this up.
It is exhausting, but it is also exhilarating. But this is exactly what we train for. We've got a job to do, and we're the people to do it.
I will say I've never seen more teamwork, more support of each other than I have right now. It is nothing but trying to figure out how do we get through this together.
We care so much. I'm going to be an advocate for a patient today, and I'm going to try and put a human touch on this whole situation.
Patients that are vented can still respond and follow commands, and they get teary-eyed when they hear family. There are some families that say, "Can I call at the same time every day?" And the answer is yes. I think we all find hope in the fact that we are seeing patients go home, because we know that for every discharge here, there's another discharge somewhere else. And if patients are going home to recover, then there's hope that we can get through this.
So I've watched that video a few times, and I think I absolutely tear up every time I've watched it. There's so much that we can unpack there. But maybe let's start with a little bit from Traci and then Marc. Could you just tell us a little bit about what we saw there? What are some differences in the ICU kind of pre and post now that we're dealing with COVID?
So I'd say there are several differences logistically, and just the entire experience is much different. Mark and I can both speak that one of the biggest difference and the biggest challenges would be the lack of family presence. I think most hospitals, nursing homes, any type of medical facility around the country, around the world, likely, they're not, either families, visitors are not allowed, or it's very limited. That's very difficult at any point, let alone when someone is very critically ill. And that human connection, that presence, that ability to hold someone's hand, that has been taken away or limited, and it's a much different capacity. And I think that that's one of the big differences, is that we are helping to care for these critically ill patients and trying to have very, very in-depth conversations, very serious conversations, life and death conversations. And now those conversations are having to occur over an iPad or over a telephone without having that face-to-face interaction, sometimes using, a translator phone or translator service, and just having that component taken away in someone's likely most difficult time of their life has been something that is much different. And I would say one of the biggest challenges that I have seen. It has really emphasized the importance, again, of having that physical touch, having that ability to smile at somebody and be able to communicate through facial expressions, because also that goes into the next point of one of the big changes, of course, is the personal protective equipment, the PPE that we are needing to wear in order to enter these patients' rooms, as well as just anywhere in the hospital. Anywhere in the hospital, we are wearing masks, but especially on these units and when we go into the patient rooms, it's a lot of protective equipment. So it is masks, respirators. As you guys saw in that video, they're complete head to toe suits, essentially, that we go in and wear. And with that, it makes communication much more difficult. And it takes a lot of time to put on, as well as time to take off. Diligence, it takes a lot of diligence in order to put that protective equipment on appropriately as well. If there's any gaps or breaks in the integrity of the system, that leaves a chance to expose ourselves and others to any potential harm or exposure. So whereas prior to this COVID outbreak, in a typical normal medical ICU, before we'd enter a patient's room, we would wash our hands or put on hand sanitizer and be able to go into the room. And so if there was a beep or a buzz or a patient needed something quickly, we were able to go into that room and address the need or the concern quickly, which is something very common, again, in the ICU. If someone needed immediate attention, we were able to be there. And that is much different as well, because regardless of what's going on in that room, it's very important that we first appropriately put on the PPE. And so, our intuition or our experience has trained us. We want to go in right away. We want to help the patient. We want to solve the problem. We want to help the situation. And we're unable to do that, knowing for the greater good and for the protection of ourselves and our colleagues and other patients and loved ones, that we have to take the time and be diligent in putting on that protective equipment. So those are a couple of the things that I think of immediately that come to mind that are different from when COVID was not around.
Yeah, absolutely. I'm going to follow up with you in a second here, but maybe Mark, do you want to kind of come in from your perspective too, some differences you've seen? And
Sure. To build on what Traci said, I think a big part of our job is to, of course, take care of the patient, but often we're interacting with a family in crisis. So the first time we meet a family is after a catastrophic event. That's why the patient ended up in the intensive care unit. And the first conversation is usually with the family members who are distraught and worried about their loved ones. Most of the time, Traci or I have never met this family before, or the patient. We're caring for someone for the first time. So you have to sit down and introduce yourself and have a heartfelt and emotional conversation about the patient's condition. And at some point during that conversation, you need to develop a bond with the family, and the family has to trust you with the care of their patient. And it's really an honor and privilege to be in this intense situation where you have to build trust very quickly, and then properly care for the patients and also help, as I said, their families, friends, and sometimes even their community. Now there are no patients around. I'm sorry, there are no families around for the patients. So you're interacting with people the way we're interacting here. And they're people you've never met before. And as Traci said, you have a mask over your face, so they can't see your facial expression. So to try to build that bond with the family and garner their trust, because they're concerned that their wife that they've been married to for 40 years might pass away. It's a huge responsibility. And it's difficult sometimes to build that trust quickly. It's become more difficult in this era where you can't be in the same room as the family members. So I think that is probably the biggest difference that we've dealt with. It's made a job where you're dealing with people in crisis even more difficult in that situation. I think some of the other things are pretty obvious. I've never really in the past worried about my own health, caring for patients. And now when you go into a patient's room, you're a little concerned that you might get sick and that you might bring that virus home to your family members. So there are added stresses to you about your own health, and you don't want to become the vector to spread it to other people. And that's happened. As in Italy, over 50 physicians have died of COVID infection because they were caring for patients that had COVID. In addition, there have been reports of people bringing the virus home to their family and having their someone in their family get sick. I think the other thing that I've learned about this virus that's different, which is going to sound obvious to the audience, but wasn't to me in the beginning, is that this affects families. So there are clearly have been times in the intensive care unit where we've had a husband in one room on a life support system and their wife in another room, because that's the way they got the virus. Or two sisters that were both critically ill in the intensive care unit. And that's a horrendous experience for that family, and something I've never had to experience before, where you had multiple members of one family sick in the intensive care unit at the same time.
So we've both briefly touched about this. Maybe you could let our audience know what are some of those ways that you are trying to kind of humanize yourself and make that connection to patients, which is often so vital, particularly during these very traumatic, very scary circumstances.
For me, and from the charge nurse side, I've been working with these patients consistently. A lot of them are hospitalized for a very long time, and I try to just make sure I introduce myself every single time. I let them know, who I am, where they are at, that they are safe, that I have been watching over them for several days or weeks. I just try to bring kind of that familiarity with it. I'm also one that's big on trying to communicate with my eyes. A lot of our critically ill patients are on ventilators, which is something that Marc will go through in a little more detail for those that don't really know what that means, or to be on these life support machines. And a lot of times, we are keeping these patients quite sedated in order to help alleviate pain and anxiety. But we have a deep belief that they can hear us. And so I use my voice, and I talk to these patients, and I talk to their loved ones, and with the hope, I guess, that they recognize my voice and that they can hear and feel my genuine compassion, my genuine care towards their loved ones, towards the patient themselves, towards the condition. So I try to use my voice and my eyes, again, because facial expressions are hard under a mask. But I just try to use those techniques, as well as holding someone's hand and stroking their hair, and just any type of communication that I can use outside from smiling or the typical tools that we're used to. And so I just try to reassure people that way, since it's so limited in any other way.
Yeah, I would agree with what Traci said. I think there are a few things that I've done differently in patients recently during the COVID pandemic. The first is, you can't ever treat someone with too much respect. So I'm always extremely respectful of the patient. And one way to be respectful is, as Traci said, is just to explain everything that you're doing to the patient. Even if they're in a drug-induced coma, I really do believe they know that you're there and they can hear you. So I always explain everything that I'm doing when I'm in the patient's room. The other thing is that I think I'm actually spending more time in patients' rooms than I was in the past, because there's no one else in the room. And you realize that you're going to be one of the few people that they interact with during that day. They don't have their family members in the room to hold their hand. So when I go into a patient's room, I'm spending more time with the patient than I was in the past. And I think, as Traci said, you can't over communicate. So I'm explaining things to the patient and with the families, even if it's through an iPad or a conference call. I really make sure that I communicate and answer all their questions even more, because you realize the family members are under even more stress because they can't even be in the room with the patient or in the hospital. And one advantage of that is people have become more comfortable using this technology. So I've actually had family meetings where there were members of the family from other countries who are sitting on a beach in Tahiti that were part of this conversation. And so it's really, the technology has connected people in a little bit more effective way that couldn't have been with the patient anyway. So I think those are the things that I've done different. Just always treat the patient with the utmost respect. You can't over communicate with them. And as I said, I'm spending more time in the patient's room because I realize they need someone to be there with them.
You all are both having to often wear multiple hats, it seems like, right? You're both standing in for those families as well as trying to do your job as medical providers. So it sounds like a lot of work. So I think everyone is very appreciative of that. What is maybe that one most important thing that families can do if they have a patient that has been hospitalized with COVID-19? So maybe both of you can answer that. If you have one answer about that most important thing people could do. And then maybe could you just talk a little bit more, share any stories you have about kind of the impact that this is having on families? Mark, do you want to go first?
Sure, I'll go first with that one. Impact on families. So I'll give you a few examples. And Traci and I both cared for both these patients. The first patient was someone who unfortunately passed away. And it's very difficult in that situation when you know someone's very, very sick and that they're most likely going to pass away. You can have someone from the family come in and be with the patient. But the hospital, for a good reason, they don't want somebody to get infected and bring it out back to their family. And they also don't want people that maybe are infected coming in. So what we arranged is we arranged for the patient's sister to come in and sit with the patient while the patient passed away or was going to pass away. But we also had an iPad so that the patient's sister and other family members could say goodbye to the patient. And I was sitting in the room with the patient and one of their family members talking to people on the iPad. And the one thing that was very nice is that people were very appreciative of the care that we'd given to this patient. And they realized that we were taking risks caring for the patient. It was very nice that they acknowledged that in this very, very difficult time for them. So one part of it is just that when people are not doing well and getting sicker, that's just adding more stress to the family because people can't be there. And we've been in situations where, in the same situation, unfortunately, when someone was most likely going to pass away, the wife could come in to be with the patient, but not their children. And that happened one other time where there was a young man who was 37 years old who came in very, very sick. We worked very hard to try to get him better, but over the course of 5 hours, he just got sicker and sicker and sicker and eventually passed away. He had two young children who couldn't come up and be with him. And his wife had to deal with all this alone without any support from her family. And just the tragedy and the grief that you could tell that she was going through was just really, really sad. And it was, you could kind of tell that the way she was crying, and she was almost acting as if she was physically wounded, because she didn't have the support system of her family in this unbelievably tragic experience. And we can try to help with that, but we're not her sister, we're not her family. So I think that's what's been the hardest for me that way, is dealing with these tragic situations, and people are having to go through it alone.
Traci, do you have anything to add about, the impact on families, and what can family members do if someone's in the ICU?
Yeah, I mean, as Marc said, it's just something that it's just impossible to relate to. We've all been faced with this situation and this time period in the history of society that we have nothing to compare it to, and so it's impossible to really put ourselves in that position until one of our own loved one is in there. But I think one of the pieces of advice, I guess, that I could give to family members is trust us. Trust that we care so deeply and so much, and we are doing our very best to show that to your loved one, to the person that is in an unfortunate situation of being in our hospital, as well as their family, but that we are taking care of them with respect and dignity and compassion, and we are doing everything they can to let them know that they are not alone, and that even though that their family is not there physically, that we are communicating with them, that we are updating them, and that we are there to care for them, and more than just physically. We are there to care for them psychologically, spiritually, emotionally. We are there, and we are doing everything we can to support them and to make sure that they don't feel alone.
Kristen, can I add something to that?
Please.
So I think the thing for the audience to remember is that in general, the majority of the patients in the intensive care unit are going to do well. So I saw some of the questions come through in the chat. What are the success rates for people on mechanical ventilation or life support systems? And what we've learned here, and I think it's true now that we understand more about the virus and the disease state, the majority of the patients that are on life support systems are going to live and are going to do well and are going to go home and live another 40, 50 years. And that's the rewarding side of working in an intensive care unit, is that you can work very hard with the patient, communicate with the family, and the majority of the patients are going to get better. So we were talking about some of the tragedy side of it, which I think is important, but I think I just want to make sure that the audience understands that people are going to get better. If we take care of people properly, which we do, and which they do at all the hospitals in the Front Range, people are going to get better. So I think families have to have hope that way and realize that they have patience and hope, and they're going to see their loved one again.
Absolutely. This is also having a toll on you all, right? Our medical workers. Could you talk a little bit about how this is personally impacting you? Traci, do you want to start?
Sure. Yeah, I can go ahead. So yeah, I mean, I'm extremely grateful for the job that I have. I have found my calling. I have found my passion in my career. I'm very grateful for the opportunity to be able to impact and improve lives, and to be there again to help support people through the worst times of their lives. And I'm very grateful for the stable employment that I have. I know that there's a lot of people who are facing obstacles that I'm not because of that, but that does come with the price. One of the big things I'm facing, for example, is my father last fall was diagnosed with terminal cancer, and he is back home in Iowa, where I'm from. And prior to this pandemic, I was going home, flying home every 2 to 3 weeks to spend time with him and to go to his palliative chemo appointments and to support my mom and help my family through this. I'm a very close-knit family, and I am no longer able to do that. And not only because I'm working in the high risk environment and I'm surrounded by, the potential, I guess, to be infected and therefore infect the outside world, and my father, who is extremely immunocompromised. So in order to protect my dad, I can't see him. And that has impacted me in ways that I can't even express. His wish was, when he was diagnosed, spend time with his family and his wife and his kids and his grandkids and travel. And all of that has just been completely taken away. And everyone has, had to do the social distancing, and the flights and the travel has been taken away. But because of the environment that I work in, one of the sacrifices that I am making is I am working with these patients and in this unit, and I can't go home and see my dad. And I can't, what I feel like is honor one of his wishes when he was diagnosed. And that has been something that I'm really struggling to cope with. Again, with technology, FaceTime, that has helped, but it's not the same. And so that has been one of my bigger sacrifices.
Wow, Traci, I'm so sorry about your father. That's heartbreaking. And I know, Marc, you work with medical nurses, and those particularly in ICU, like Traci. So how has this impacted you personally? And then maybe could you shift into talking about some of these concerns and challenges that the medical profession is facing?
Yeah, I think I try to look for a silver lining that way. As I said, the majority of the patients get better. I think the other thing that this has done is that crisis can either tear families apart or pull families together. And I think in the hospital, this has really pulled people together. A lot of the walls and barriers that existed in hospitals between different service lines have been broken down. And everyone sort of sees a common vision and mission and goal of why we do what we do. So I have seen a lot more camaraderie and collegiality and collaborations that have existed in the hospital. Again, not that it was a problem in the past, but people have really risen to the occasion. And I've never run into anyone recently that if you ask them to do something, and their answer is absolutely. We need someone to do an extra overnight shift. Absolutely. We need someone to do an extra week caring for patients. Several people, let me know, whatever I can do to help, I'll help. So I think sometimes in crisis, you see the good in people and comes out. And I think that's been shown in crises all along the way. So I think that's one benefit. I think another thing is that I don't think we've always had stressful jobs, and some of the stress has been the unpredictability. You come into work one day and you don't know if 3 very sick people are going to come into the intensive care unit or 10. So that unpredictability can lead to stress. And I think what this pandemic has added to that is we don't know how long this is going to last for. So there's unpredictability on a day, and then as we're trying to plan things for the summer or the fall, there are models and we have some ideas, but there is unpredictability there, and I think that's led to some increased stress that way. I think the other thing that's kind of been nice is that everyone needs a little external validation now and then, and when we walk through the neighborhood, when I walk my dog through the neighborhood, there are signs in people's yards. We love our healthcare professionals. Thank you for taking care of people, for not just healthcare professionals, people work in grocery stores, etc. And it's nice to see that. So I think when I've had a particularly bad day, I take the dog for a walk and see those signs, and it kind of cheers me up.
Yeah, I see them all throughout my neighborhood too. And I'm not in your line of work, but it's we're all very appreciative. The comments are pulling in left and right about the gratitude and appreciation that our audience is sharing with you. So just so you know, I'm going to take a moment and say thank you again for all you're doing. Okay, so let's transition our conversation a little bit into maybe a little bit more of the technical stuff, right? What have we been learning over the past couple months, right? About how hospitals work, how collaboration is happening, and particularly, everything as simple as do we have enough of that personal protective equipment that really, all these extra levels and layers. So what are we learning? Let's start with Traci, and then we'll go over to Marc, and I think we've got a lot to unpack here. So Traci, if you want to start?
Yeah, I get elaborating on what you had just said, at the hospital I work at, University of Colorado Hospital. And I think this, from what I've heard, kind of extends to other hospitals in the metro and the state area, at least, is that we have been very fortunate that we have the equipment we need overall. I know that, again, our institution and many have worked very hard and focused very heavily on this because they understand the importance of our safety and therefore the safety of our patients and their loved ones and the community. And so that has been a very heavy focus. So I felt very fortunate with that because I know, we've all heard the stories from New York and other places where that's not the case and they were so overwhelmed that there was not enough. And I feel very, very fortunate that that's not something I've run into. I guess also on the technical side, or the hospital side, that I think we want to remind people that hospital is a safe place to be. That with this going on, a lot of the elective surgeries and a lot of other things were kind of canceled or dimmed down a little bit, but we do want to assure people that the hospital is a safe place to be, and that if you are having a situation, having a medical condition, that you are safe to come in and get that treated and get yourself evaluated. I think that that's a very important piece to make sure that we throw in there as well. Let's see. I don't know. I might let Marc elaborate on this a little bit more, but overall,
Sorry, go ahead. Yeah, I was going to say, and Traci or Marc, if both or one of you could address supplies too, right, of personal protective equipment. Do we have shortages and things like that? I know it's a concern for many out here.
Yeah, I think we in Denver benefited that the COVID pandemic hit us a little bit later than other parts of the world. And the world's gotten very small and people communicate. So the pulmonary critical care community, people know each other. So we were calling people in Italy and China and learning from their experience that way, and even New York City. So when it came time to prepare, we at our hospital and across the entire Front Range were very well prepared for this. So it got very busy here, but we were never at a shortage of personal protective equipment or ventilators. I think part of that had to do with the social distancing, that we had a lot of patients, but we could care for them all. I think the other thing that comes out of that is, what have we learned over the last 8 weeks? And it's a ton. And it's a ton because people are communicating that way. And we were talking to people in other areas and saying, are you seeing people with a lot of blood clots? Because I think we're seeing more than that. And they were saying, yes, they are. So I think over a very short period of time, and I really do think this is unprecedented in the medical history, that people are communicating and learning sort of in real time to take better care of patients. And there are clearly things that we've learned that we're doing slightly differently now that I think are leading to better outcomes. We feel also more comfortable. One thing I said before is that I think medicine is pattern recognition. And the more times you see the pattern, the better you're able to care for that patient. And we've seen this pattern of people with COVID infections in the intensive care unit repetitively over the last 8 weeks or 9 weeks, and we're more comfortable and therefore can anticipate problems better so we can better care for patients. I think those are, when you talk about technology, the communication has been an advantage because we're all learning from each other to the betterment of patient care.
Mm-hmm. Marc, I know you have a couple photos that show ventilators in use. Could you show those and just talk to our audience a little bit about the use of ventilators, how that's changed, and just kind of what that environment looks like, since I know that really is a lot of your expertise.
Yeah. Can you see that first photo, Kristen?
Yep.
So I just wanted people to see this. This is a patient in an intensive care unit, and you can see how technology driven the care of these patients are. There's one patient in a large room with a lot of different machines that are working to keep the person alive and save their life. This is a picture from Australia, and it shows that when a healthcare system got overwhelmed, which clearly happened around the world, that people had to be put in larger areas where they didn't have their own room. So this is a row of patients that are on a life support system, a ventilator with a tube down their throat, which I'll show in a second. And you can see all the healthcare professionals wearing personal protective equipment to care for the patient. This is another picture of 3 healthcare professionals caring for a patient. This is a physician putting one of the breathing tubes into a patient, and here's the breathing machine. And just to explain the different types of life support systems that patients will need in an intensive care unit, this is a mechanical ventilator. So a tube is put down the back of the patient's mouth into their windpipe to help, and it's hooked up to a machine here that then breathes for the patient. And that's a life support system. The way I describe it is that if someone was on a life support system and you took them off of it prematurely, they would pass away. So that machine is keeping the patient alive. And 2 other forms of life support systems that we use commonly in the intensive care unit is a continuous or artificial kidney or dialysis machine. There's a catheter that's in the patient's vein. The blood comes out and it's cleaned in this machine, which is what your kidneys do, and then the blood goes back in. And another type of life support is we think about people with their blood pressure, normally think their blood pressure is too high and they need a medication to lower their blood pressure. When people are very, very sick, their blood pressure drops very low and they need very potent medications to keep their blood pressure up. And those are medications that are infused in through their vein continuously to keep their blood pressure up. And again, that's another form of life support. And the last one is something called, it's sort of an artificial lung, or it's called extracorporeal membrane oxygenation. Because sometimes when someone's on a breathing machine or a ventilator, the pushing the air into the lung, if the lung's damaged, can damage the lung even more. So even being on a ventilator can be damaging. And in that situation, what we do is we put a large catheter into someone's vein, their blood comes out, it goes into a machine that then puts oxygen into the blood, and then that blood goes back into the patient. So those are just some of the life support systems that we utilize and have been utilizing consistently for these COVID patients to try to save their life. So it's a very technologically intense place, but it's to the betterment of the patient. And by using this technology and these life support systems, you support the patients, and then they eventually get better and you get them off the life support systems and they go home, which is very rewarding.
Absolutely. Wow, great photos there, Marc. Thank you for that. I do want to kind of start getting close to wrapping up our conversation here and discussion. So perhaps some final thoughts on, this seems to have maybe greatly changed how our hospitals run, right? So is there something that's changed that you think is a permanent change to our healthcare systems? Or, is there some sort of longer term concern or silver lining that you're seeing coming from all of this really COVID heavy focused work in the ICU? Traci, do you want to start?
Sure. Yeah, I think like Marc had said before, one of the big things that, I hope and I'm very confident will carry on moving forward is the increase in interdisciplinary collaboration. Again, that wasn't necessarily an issue before, but just the increase, and I guess the respect and admiration and the communication between all the disciplines, both within our hospital and within hospital systems around the city and state and country and the world. I think that that's something moving forward that we can learn from in order, I guess, for the betterment of our patients and for medicine. And so that's one of the silver linings that I see moving forward, is that we can learn so much from each other for the betterment of our patients. Yeah, and I think just moving forward, preparedness, learning, knowing that something like this may flare up again and things like this can continue to happen. And so just making sure that we continue to be prepared for things that may very well come up again in our lifetime.
Absolutely. Thank you. Mark, do you want to add to that?
Sure. I think for me, I always know I work with really great people, but watching the people I work with in this time of crisis, I've never really been prouder of all the colleagues that I've worked with and the amazing hospital employees that we work with on a daily basis. It's sort of been an honor for me to witness their extraordinary efforts to care for the sickest patients in the intensive care unit. So that's really been really nice to see that way. I think in terms of how it's going to change healthcare, I think a lot more is going to be done virtually. There's, especially in an outpatient setting, which is not the intensive care unit, but I think people are going to use the technology to care for patients more. The thing I do worry about, Kristen, that you brought up and we've talked about is when this is all over, I think a lot of healthcare professionals are going to be exhausted and burned out, as we would say. And I think we're going to really, as a healthcare system and as a society, make sure that we attend to the needs of all the healthcare professionals that are going to need to focus on self-care and well-being to recover from this crisis. You can kind of gear yourself up in the moment, but when it's all over, I think there's going to be some need for psychological support for a lot of the healthcare professionals. And I think we should just anticipate that and plan for that. And I think in this era where people are becoming more in tune with mental health issues and their stigmas involved with that, I think this might be a way to try to remove the stigma from mental health issues so that people realize there's nothing wrong with the healthcare professional. We just have difficult jobs and have seen difficult things and need help to recover from that. So I kind of hope that this can help unstigmatize the mental health issues that exist in our society.
Mark, that's wonderful. Yes, absolutely. I 100% agree. As a person who has family members who have dealt with serious mental illness issues, I can anything to help destigmatize mental health for everyone, no matter what walks of life or what jobs they come through, is hopefully a really good silver lining on the other side of this and something we need to focus attention on. I know we're out of time and we had 1 million questions. We will try to maybe get some answered in a follow written up afterwards for those who didn't get them answered, but we never do have enough time. I am so extremely thankful and grateful for both Traci and Mark's time for joining us today. I know both of you are probably both exhausted and you're working crazy hours no matter the time. So we are so appreciative of you being able to spend some time with us here on Monday morning. Please extend our warmest thanks to all of your colleagues as well. We really appreciated your time. So just for everyone tuning in, thank you for joining us today. We're really excited to continue on with this series into June, but just so you know, next Monday is Memorial Day, and so we're going to take a break on Memorial Day next Monday, but we'll be back on Monday, June 1st, so hopefully you'll join us there. We're going to kick off our June series with a lot of fun topics that we heard from you wanted to hear about. Yeah, I should say fun and serious and exciting and science-based, of course, all of those wonderful adjectives to describe it. But first up on June 1st, we're going to have a researcher and professor from Colorado State University, Jude Baham. He's going to be talking about mobility patterns and social distancing. Kind of in other words, he's going to be talking about how different counties and regions and communities, as well as demographics, have been responding to some of the social distancing and some of the orders to do that. What does that look like? How are people moving throughout the communities? And what does it look like on a state-based level, and kind of make that a little bit larger too. So he has a new paper that just came out last week, and so we're going to be talking about some of the details from that research paper, as well as some of the technology they're using to kind of show what this looks like as far as mobility. Thank you again to our partner, the Colorado School of Public Health, as well as to all my museum colleagues who make this series possible. Once we have registration live for the next one, you can find that there on that landing page I mentioned, institute.dmns.org. You can also find past recordings, written recaps, and everything else about this series that you can kind of share broadly. And I just want to say thank you to all of our members, all of our donors, all of our viewers for tuning in. This has really been a really eye-opening series for all of us here at the museum, and it's made possible by many, many people involved. So thank you. And I actually wanted to end a little bit on a thought I had. I've actually been reading a little bit about gratitude, and I think it is very relevant and timely with having Traci and Marc here to just, you know, recognize and be very grateful for those who work in their medical communities. With Memorial Day coming up, I know a lot of people have gratitude to that. And so I wanted to end our today's talk with a quote. I actually came across two and I couldn't decide which one. So I'm actually going to share both to end out today's. The first one is of course, John F. Kennedy, or President John F. Kennedy. And he said, as we express our gratitude, we must never forget that the highest appreciation is not the utter words, but to live by them. So I thought that was a great way, because I know both of you are living by those actions, not just those words. So thank you for that. And then the last one is a little bit more positive, and it's from Maya Angelou. And she had written, "This is a wonderful day. I've never seen another one before." So thank you both for joining us. Thank you all for tuning in. And I hope you have a great rest of your Monday and a great rest of your week.
Thank you. Thank you for the opportunity.
Thank you both.